Michael Dickinson. I'm a haematologist and disease group lead for aggressive lymphoma at Peter MacCallum Cancer Centre and Royal Melbourne Hospital. And today I'll be talking about diffuse large B-cell lymphoma and giving an overview of standard workup and therapy for this disease. We'll be running through the different types of lymphomas and how we classify lymphoma generally, and I'll be talking about the basics of the side effects of treatment and how treatments work, and talk a little bit about some emerging therapies. Lymphoma is a cancer of lymphocytes, and just like any other cancer, lymphoma arises from a normal counterpart cell type. So, for example, breast cancer arises from breast cells and lung cancers arise from lung cells. Well, lymphoma arises from lymphocytes, which are a particular cell type of the immune system that we typically think of as living in lymph nodes, but which also is found in blood and also found in many of the normal tissues of the human body. And so it's the fact that it arises from lymphocytes that makes it a lymphoma, as opposed to whether it's in the lymph nodes or not. And in the case of the lymphoma we'll be talking about today, it can occur in many of the tissues of the body. Why does cancer arise? Well, cancer occurs when normal cells lose their programming due to some abnormality, and that leads them to growing out of control or simply not dying when they should die, and the overall effect is an abnormal growth. It can be an issue with the recipe for the cell, so the DNA in the cell can become mutated, or the way that the cell reads the DNA, what we call epigenetic changes, can occur over time. And there can be immunological factors. So we know, for example, that some lymphomas arise from patients who are immunodeficient for some reason or another. But for many patients, we never find a single cause that leads to lymphoma arising in that individual patient. And sometimes it's a multitude of these factors, so many different hits that leads to a lymphoma arising. Inherited factors are relatively uncommon as causes for non-Hodgkin lymphomas, but there are some inherited factors that have been identified. But in most patients that I see, I can rarely attribute a lymphoma to some inherited factor. Non-Hodgkin's lymphoma accounts for the majority of all lymphomas, and Hodgkin lymphoma accounts for about 30%. Within non-Hodgkin lymphoma, the single most common lymphoma is diffuse large B-cell lymphoma, with follicular lymphoma being almost as common in most populations. And diffuse large B-cell lymphoma is the kind of lymphoma I'll be talking about today, and that represents about a quarter of all the lymphomas that we see. The lymphatic system is all through the body and basically exists of various vessels that are a bit like blood vessels but aren't actually in the bloodstream, that run through all the tissues. The lymphatic system and lymphocytes live within bone marrow but also live within other organs. It actually lives throughout the gastrointestinal tract, but there's a lot of the lymphatic system in the liver and the spleen, and both of these organs can become enlarged in lymphoma. And as I've mentioned already, lymphoma can occur in pretty much any tissue in the body. There are lots and lots and lots of different types of lymphoma, and this list that I've put here is not meant for you to read, but just to show that there are so many different types of non-Hodgkin lymphoma, as well as Hodgkin lymphoma. And the point that I'm making here is that the crucial first step to treatment is accurate diagnosis. So having a good tissue biopsy, an adequately sized biopsy so that the pathologist can see the abnormal lymphocytes within the tissue properly is a really important first step. What we know when we're looking to treat cancer is that people do well or do better if the diagnosis is correct, so that the correct treatment is selected. And lymphoma is a particularly thorny area, and ideally you want to know that the pathologist who's looked at your sample is used to looking at lymphomas and can tell the difference between all of these different types of lymphoma. Diffuse large B-cell lymphoma is one of the more easy to pick lymphomas, and it's characterized by very large cells throughout the tissue, and I'll show you a picture of that in a minute. I want to talk a little bit about what drives what we do. So as haematologists, we choose our therapy based on clinical evidence. And the clinical evidence that we have depends upon how common a disease is. So the best kind of evidence at the top of this evidence pyramid is a randomised double-controlled clinical trial. And that's where a large group of patients are randomised within a clinical study so that a computer decides what treatment is received, and the patient and their doctor don't know what the treatment they're receiving is. And if you demonstrate a difference between two treatments in that context, that's the best standard of evidence. But those trials are extremely expensive to run, and they require a lot of patients, and patients and doctors have to be adequately blinded. So technically, these are very challenging studies, and there are relatively few of these studies run. For diseases that become more and more rare, there's often less and less evidence about how we should treat patients because of the rarity of the diseases. And for some of the things that I'll be discussing today, we don't have randomised, controlled, double-blind trials to inform us. We have something less, like randomised studies that aren't blinded, or case control studies where there isn't a randomisation, but a group of patients is treated one way and then compared indirectly to a group of patients treated the other way, which is nowhere near as good as a randomised study to inform our decisions. And it's important whenever you receive information from a haematologist that you understand the strength of the evidence that underlies that information. So for some of the things I'm going to discuss, we have really strong randomised clinical trials, and for other things we have case series that inform the advice that we give. So for some of the very rare lymphomas like T-cell lymphomas, we only have case series or case studies, which makes the evidence more difficult to be concrete and firm about. So with all lymphomas, there's a common approach to staging. Usually a patient will present with a symptom which then guides the next staging test, be it a lump in the throat or a lump in the neck or a lump in the groin, or fevers or weight loss. And typically it's some kind of imaging that leads to a biopsy. Chest x-rays are often performed in patients who present with shortness of breath, but often it's a CT scan or a PET scan that provides really good staging information. CT scans mean computed tomography, and this is essentially cross-sectional imaging of a patient. So x-rays taking a slice through a patient so that we can see all the organs in the body in great detail. This is a very accessible test. PET scans are just a little less accessible. This involves the same basic idea, so cross-sectional imaging using a CT scanner, but with an additional scanner on top called a PET scan. PET stands for positron emission tomography. And in this scan, we use a low-dose radioactive dye which goes to the tissues that are metabolizing glucose. And we can see that tissues that are metabolizing glucose a lot glow hotter on the scan. And because lymphoma metabolizes glucose a lot, lymphoma is often hotter on the scan than the normal tissues around it. So PET scans have become a very important part of the staging of lymphoma, and particularly important in the staging of diffuse large B-cell lymphoma. We also use bone marrow biopsies, which for many patients are a very scary idea, but really not something you should be too scared about. There's a lot of myth and rumour about bone marrow biopsies, but if they're performed by an experienced operator, they're usually reasonably well tolerated and can be done as an outpatient. Here at Peter Mac in Royal Melbourne, our approach is to do them in the radiology department, and a patient will be asked to fast, that is not to eat or drink anything on the morning of the procedure, and then the patient can have some mild sedation, Valium-like medication that can help calm the nerves, and often means that you don't remember the procedure, but doesn't equate to a general anaesthetic. And the reason we don't use general anaesthetics is because general anaesthetics come with risks and complications. And so this way of anaesthetising and sedating is a much lower risk way of doing a procedure. Now, the key way that we prevent pain and discomfort from a bone marrow biopsy is a local anaesthetic. Bone marrow biopsy is performed in the pelvis. And the pelvis, if you put your hands on your hips, that's your pelvic bone that you're putting your hands on. The hip joint is the joint between your femur and the pelvic bones. We go nowhere near your hip joint, and we go nowhere near your spine, but we go into the pelvic bones, which are big, thick bones that are very strong. And we use a local anaesthetic to numb the area and then take a bone marrow sample using a needle and the inside contents of the needle to give us a matchstick size core biopsy, which is looked at under the microscope. Now that test is very important for staging in lymphoma, and I do that in all patients with diffuse large B-cell lymphoma and follicular lymphoma and most other types of lymphoma. And it gives us information in most cases above and beyond the PET scan, although it is becoming clearer that PET scans are able to tell us whether diffuse large B-cell lymphoma is in the marrow. It doesn't tell us whether other types of lymphoma is in the marrow, and it is possible for patients to have more than one type of lymphoma at a time. So the bone marrow biopsy is a very important test there. We also do blood tests, and the blood tests are really about telling us about your normal organ function. Is the liver okay? Is the kidney okay? And is the bone marrow making cells in the normal and expected way? And that's all about telling us about how you'll tolerate treatment and give us a hint about whether the bone marrow has been involved. We sometimes perform flow cytometry, which is a test that is designed to look at the markers on the surface of lymphocytes to tell us whether lymphoma is in the bloodstream. But this isn't performed universally and does depend sometimes on the clinical way in which a patient is presented. We do other tests that may affect the way we treat a patient, and it's our universal practice to check for things like hepatitis B, hepatitis C and HIV, because those viruses can change a patient's tolerance to our treatment, and so it's very important that we know what's going on there. This is an example of what we see when we get a PET scan, and as you can see, those slices have been merged into a whole body scan, and these dark spots, which in the cross sections are in coloured red, point to where the lymphoma is. And these are the different lymph node regions, and in this particular case there's bony involvement of the pelvis down here, and there's some multiple sites of lymph node involvement in other parts of the body. We always expect to see that the bladder is hot in a PET scan and that the brain is hot in a PET scan, and often the heart is hot in a PET scan as well. And so sometimes patients look at this and think, oh, I'm looking at lymphoma, but actually that's just where we expect the dye to normally go in this type of scan. When we stage lymphoma, we give it a name, and you will have heard before stage 1, stage 2, stage 3 and stage 4. And this is called the Ann Arbor staging system in lymphoma. And the basic idea is that patients who have stage 3 lymphoma have disease on either side of the diaphragm, and patients who have stage 2 lymphoma have disease on only one side of the diaphragm, but in 2 spots. And patients who have stage 1 lymphoma have it just in one spot or one lymph node. Stage 4 is when lymphoma is at multiple sites through the body, including involving organs outside the lymph node system. And the thing to remember here is that the staging system is less important in choosing therapy and less important to your overall outcome than what the staging system might be for other kinds of cancers. And because there's a lot of press around cancers and a lot of celebrities talk about their experience with cancer and mention the staging that they have, it can lead to people thinking if they have stage 4 lymphoma, they have an unacceptable chances of a good outcome, which is not the case in lymphoma the way it can be in other types of cancers. And so I think it's very important here that when you're talking to your doctor about staging, that you realise that staging is useful for us in picking the therapies that we use, but not so useful in telling you about how you'll go. And don't despair if you have high stage lymphoma. How then can we talk to you about your outcomes of lymphoma? Well, we use a word for this, and it's prognosis. And prognosis means a doctor's best estimate of your future outcome with the treatment that you're receiving. And of course, there are a number of things that tell us about prognosis. Obviously, if treatment is not given for certain types of lymphoma, the prognosis is poor because lymphomas need to be actively treated in most cases. And so the ability to deliver treatment is a very, very important prognostic factor. And I personally find it's one of the key prognostic factors. We all know that some patients are too frail to have active treatment for the lymphoma. That means that the overall outcome of the lymphoma is likely to be less good than in a patient where treatment can be given. So that's the first thing. The second thing that I look to when I talk to patients about their prognosis is how they are at the start of treatment. So if a patient is up and about and feeling relatively well, then generally speaking, we think that they will, if they've started well, they're likely to go well through treatment, tolerate the treatment, receive it on time, and then do as well as possible as a consequence of the treatment given. And we call that performance status. So that's a term that doctors use to describe the overall fitness of a patient. Other factors, well, stage does play a small factor in our overall way of thinking about prognosis, but not an overriding factor the way it might do in other diseases. And then there are biological features of the lymphoma itself that give us some indication about whether it's a better player or perhaps less likely to be a better player. But overall, in non-Hodgkin lymphoma, we're generally pretty optimistic about outcomes, and in diffuse large B-cell lymphoma, that's the case as well. You have to remember that when a doctor talks about prognosis, they're talking about how 100 patients like you might go compared to 100 patients who have a different outcome. But none of us ever know for an individual patient how that person is going to go. And if a doctor says that you have a lymphoma that looks like a higher risk lymphoma, that doesn't mean that your outcome will be poor. It just means that that compared to patients with lower risk, 100 patients with higher risk lymphoma do a little less well. But it doesn't mean that you're necessarily going to do badly. And so it's important that you remember that when you're talking to your oncologist about prognosis, that there's a lot of grey around this, and it's not a crystal ball for how an individual patient is likely to go. I have lots of patients who've had what I would consider to be poorer risk disease who've had perfect outcomes. And it's very important to remember that, even if you're faced with a lymphoma where your oncologist says it has a poorer risk. We use plain English to describe how we expect lymphomas to behave. You saw the list of all the different types of lymphomas. Well, we can group those on the basis of their clinical behaviour into indolent, aggressive, and very high-grade lymphomas. And that's really on the basis of how they behave if they're left untreated. So an indolent lymphoma, of which follicular lymphoma is the best example, but other diseases like chronic lymphocytic leukemia, marginal zone lymphoma, lymphoplasmacytic lymphoma, even mantle cell lymphomas, certain types of mantle cell lymphomas, are considered indolent, which means that a patient can often go without treatment for a long period of time, and the lymphoma is not likely to cause major issues during that time. And so it also means that after treatment, patients generally respond well to treatment, but with the indolent lymphomas, there's a slightly higher chance of relapsing, but then responding well in the long run to further treatment. So indolent lymphomas are more of a kind of smouldering, low-grade type of clinical behaviour with less urgency to treat. High-grade lymphomas include diffuse large B-cell lymphoma as the best example. And the key point here is that there is urgency to treat. If you have a diagnosis of a high-grade lymphoma, then treatment needs to be given, otherwise it will grow relatively rapidly. And as I've mentioned, diffuse large B-cell lymphoma is the most common example. Many of our T-cell lymphomas, but not all of the T-cell lymphomas, fall into the high-grade example, and we think of Hodgkin lymphoma as generally being a high-grade lymphoma that warrants active treatment. Most mantle cell lymphomas are high-grade lymphomas, but mantle cells are a difficult histological subtype, and there is a range of clinical behaviour for that particular disease type, as you'll hear from other speakers. The very high-grade lymphomas are limited to acute lymphoblastic leukemia, which is in fact a kind of lymphoma that can present potentially in the bone marrow or with a lump in the chest, and that can move very quickly over a matter of days and require urgent therapy. And Burkitt lymphoma is one of our most aggressive lymphomas. Again, aggressive not because it has a poor outcome, it actually has a very good outcome, so long as you can get the treatment in quickly. So these terms, indolent, aggressive, and high grade, don't tell us about how you're going to go, they just tell us about how urgently we need to treat you. And so don't be scared if your doctor says you have an aggressive lymphoma, it just means we need to act. It doesn't mean that you'll do badly. I mentioned before that the words that we use to describe lymphoma are actually plain English words that the pathologist would use to describe what they see down the microscope. So diffuse large B-cell lymphoma literally means that in the biopsy we see a a diffuse spread of large cells through the biopsy sample. And we're used to looking to see that the cells are larger than expected for a lymphocyte and that they're spread in sheets usually throughout the biopsy. Follicular lymphoma, by contrast, is in follicles throughout the biopsy and doesn't have as many large cells in it. And really that's the art of histology. Histology is the word that we use when a pathologist looks down the microscope and looks at tissue, and it's looking at these cells and their layout compared to each other that defines what kind of lymphoma you have. And diffuse large B-cell lymphoma, as I've mentioned, is usually one of the more straightforward diagnoses. It's the most common non-Hodgkin lymphoma, about 25%, and it presents in patients around the age of 65 most commonly, but can happen in any age group, males generally more than females. And patients present usually with a lump or sometimes B symptoms. You might hear the term B symptoms from time to time in the lymphoma literature, and that refers to fevers, unexplained fevers, so fevers that can't be attributed to some other cause, weight loss, or night sweats. And usually night sweats are the most difficult to put your finger on, particularly if you have other reasons for having sweats. It can be really difficult to sort out whether something is a night sweat from the B symptom point of view. We think of night sweats as being drenching sweats, the sort of sweats that would require the sheets to be washed and changed and occurring generally at night time. And that's a clear-cut B symptom. In non-Hodgkin lymphoma and diffuse large B-cell lymphoma, these are relatively rare to get night sweats, but it is possible. Night sweats are just a bit more common in Hodgkin lymphoma in my experience. Now, diffuse large B-cell lymphoma, it turns out, actually has multiple different subtypes. So when a pathologist looks down the microscope and sees a diffuse sheet of large cells, it could actually be one of several different subtypes of lymphoma, but we use this umbrella term, diffuse large B-cell lymphoma, to describe it. And the pathologist's eyes often can't tell us a lot more. We need special tests to tell us more. So histology is what the pathologist sees. Immunohistochemistry is when we use special stains on the tissue to tell us what proteins are on the surface of the lymphoma cells. FISH are when we use special stains to tell us about the genomics of lymphoma, and then we can actually do genomics and actually look at the DNA within the lymphoma cells. And what that tells us is that we can divide diffuse large B-cell lymphoma into different subtypes. And I have to emphasize here that that doesn't necessarily mean we treat the subtypes differently. It's just that we're learning as a medical community what particular cell type the lymphoma has arisen from and what the genetic drivers are for those types of lymphomas. And so one of the subtypes is germinal center B-cell lymphoma, and then another subtype is activated B-cell lymphoma, which, depending on how you read things, can also be called a non-germinal center B-cell lymphoma. So these are common terms that are now used by haematologists, but again, don't usually really direct the way we treat. There's another type of lymphoma that can be picked up on by protein stains, and this we sometimes see haematologists call double expressor lymphoma. And that's when, on immunohistochemistry, we see increased expression of MYC and BCL2. So that is, we look at the stains on the surface of the lymphoma cells, and we see that a stain for MYC and a stain for BCL2 are present above a certain threshold of cell numbers. And basically, usually it's a coloured dye that is looked at by the pathologist. And there is a term called double expressor lymphoma, meaning that both of these two proteins are present, and that can exist irrespectively of whether you have a germinal center B lymphoma or an ABC lymphoma. And that's all down to protein on the surface of the cells and special stains that we use. We can look for rearrangement of the genetic material by looking at FISH, and FISH stands for fluorescent in situ hybridization, and there is a disease called Doublehit lymphoma, which many have thought of as being a subtype of diffuse large B-cell lymphoma. And I'm going to talk about Doublehit lymphoma a little bit more because we are beginning to treat that as a different disease, or at least think about it as a different disease. But for most intents and purposes, the treatments that are available for diffuse large B-cell lymphoma are likely also to be available for double-hit lymphoma. So most of the time, all you need to know about a diagnosis of diffuse large B-cell lymphoma is that you have a diagnosis of diffuse large B-cell lymphoma. Only about 10% of patients will have this other diagnosis, double-hit lymphoma. And so for the majority of patients, that's not actually relevant information that you need to know. The diagnosis of double-hit lymphoma, as I've mentioned, requires FISH, and it's important to understand that FISH is not routinely performed by lymphoma pathologists in Australia because Medicare doesn't cover the costs of FISH. And so your haematologist has to specially ask the pathologist to do FISH, and different pathology companies and different pathologists around the country will have different thresholds about where they think FISH is required. And the reason is FISH is a little bit more expensive, and there's a risk of an out-of-pocket cost to you of several $100s because the pathology company needs to cover its costs for doing FISH. And I raise this because you can't assume that it's been done. Some hospitals do it routinely, but many hospitals do not. Now, things get really hairy when we talk about double-hit lymphoma. We've been treating double-hit lymphoma as diffuse large B-cell lymphoma for quite some time, but recently the World Health Organization realized that FISH, this way of looking at lymphoma cells that can be just a little bit more accurate than the pathologist's eye, was picking up on these rearrangements of MYC and BCL2 in lymphomas that didn't look like diffuse large B-cell lymphoma. And so you can see here on this diagram how the World Health Organization is changing our labels for lymphoma. And here, under morphology, is what the pathologist sees. Phenotype and genetics are what FISH might tell us and what the protein surface markers might tell us. And then this is the ultimate diagnosis. And you can see that under diffuse large B-cell lymphoma, if you have a patient with diffuse sheets of large cells under the microscope, you can see that they can have something just called diffuse large B-cell lymphoma not otherwise specified, which accounts for the vast majority of cases that we see. A small percentage of patients will have MYC and BCL2 or BCL6 rearrangements. They're the lymphomas that we call double-hit lymphoma. And it turns out that you don't need to have diffuse large B cells in the biopsy. You could have what we call a blastoid morphology, which is what the pathologist sees when they look down the microscope, or a Burkitt-like morphology, which is another way that lymphomas can look when looking down the microscope, and still have something called double-hit lymphoma. So if you think of it as being that some double-hit lymphomas are diffuse large B-cell lymphomas, but not all double-hit lymphomas are diffuse large B-cell lymphomas, that can be helpful. And the other thing to know is that there's this other entity called high-grade B-cell lymphoma, and so this term high-grade B-cell lymphoma is now become a bit of a dumping box. When someone has diffuse large B-cell lymphoma with double hit, it's now called high-grade B-cell lymphoma with MYC and BCL2 rearrangements, a very mealy-mouthed title. And so for the purposes of this talk, I'm just going to call it double-hit lymphoma. But it's also possible for patients to have something called high-grade B-cell lymphoma, not otherwise specified, which can be a type of diffuse large B-cell lymphoma, but also these other types of histology. It's really confusing, and I imagine that you'll rewind and play this video and still find it difficult to understand, and I apologise for that. This is an emerging classification, and pathologists are sometimes sticking very rigidly to this new diagnostic classification, and other pathologists are still using terms like diffuse large B-cell lymphoma with double-hit disease. The other point to make is that a pathologist may issue several reports, and they may start and say, well, when I look down the microscope, it looks like diffuse large B-cell lymphoma, and so I'm going to call it diffuse large B-cell lymphoma. But now that I've got the FISH result, which often comes through several weeks later, I'm going to change the terminology to high-grade B-cell lymphoma. And it's important to understand that that doesn't mean that the pathologist was wrong at the start. It just means that some of the genetic information came through and modified the label that was given to the lymphoma. So now over to treatment. Now, the principles for treatment for double-hit lymphoma and diffuse large B-cell lymphoma overlap a lot, and I'm going to talk first about diffuse large B-cell lymphoma. And the key principle to understand here is that diffuse large B-cell lymphoma is treated with chemotherapy as the backbone. We use this antibody treatment called rituximab, which is an anti-CD20 antibody. CD20 is it's what's called cluster of differentiation, and it's just a marker that's on the surface of the lymphocytes. And this particular antibody targets that and helps the chemotherapy do its job without adding too much toxicity. And that's been around now for well over a decade, and we've shown through really good randomized clinical trials that rituximab makes chemotherapy work by tens of % better than chemotherapy alone. Now, the most common regimen that's given is called R-CHOP, which is most commonly given every 21 days. And it's basically all of the intravenous components are given on the first day of treatment, and then you take prednisolone for 5 days. And R-CHOP consists of cyclophosphamide, doxorubicin, vincristine, and prednisolone together with rituximab. Now, you'll get a lot of education about the potential side effects, and it's not within the scope of this particular topic to go through all of the side effects. But the broad brushstrokes that you should understand is that typically this is given for 6 cycles of treatment. For patients with the lowest risk, earlier stages of lymphoma, it may be given for 4 cycles of treatment, and it may or may not be given with radiation for patients with early stage disease, where radiation can encompass all of the disease within a radiation field. That's often a very custom-fit decision that is made by your haematologist and something you can discuss with them. But the principles are, as I've mentioned, given every 21 days. This is conventional chemotherapy. It's usually very well tolerated and delivered as an outpatient in young patients and old patients alike. Sometimes for our oldest patients, we have to adjust the doses of chemotherapy down to make it more tolerable. Things like nausea that people used to worry about are much, much less common because we're able to prevent nausea. The most common side effects that I talk to patients about are low blood counts and risk of infection from that, loss of hair due to this particular drug, doxorubicin. A low percentage of patients can have damage to the heart in the long run, which is why a heart scan is a very important part of your workup. Prednisolone, these tablets that you take every day, can cause subtle effects on you immediately in terms of your sense of well-being. They can make you feel better and shrink the lymphoma quickly, but they can also make you a bit high and a little bit manic. And for some people, that means feeling great and not needing as much sleep. And for other people, it means sleeplessness and argumentativeness and a subtle change in personality and a short temper because you're just a little bit amped up. So you have to watch out for that side effect from prednisolone for those couple of days that you're taking it. Some patients find that after that 5 days of prednisolone, having been on a bit of a high for 5 days, when the prednisolone is taken away, it's like having the rug pulled out from under them, and they can feel very low, and we call that the letdown effect. And so sometimes on a second or third cycle, if a patient's reporting that to me, I adjust the prednisolone dose so that there's a bit of a taper on days 6 through to 8 to get that letdown effect, make that less common. The vincristine is a neurotoxic agent. It's very good anti-lymphoma treatment, doesn't do too much damage to your blood count, so it's a good treatment like that and a good drug for combination, but can cause tingling in your fingertips and toes, which can progress to loss of strength in your hands or in your feet. And it's really important that you communicate this with your haematologist because we can adjust the doses of vincristine when we know that's going on. Many of those side effects are reversible with time, but they're not reversible in 100% of patients, and it's really important if you're having difficulty doing things like doing up your buttons or making a cup of tea because of change in sensation in your fingertips that you communicate that with your haematologist. Again, most of these side effects are reversible and after going through chemotherapy, again usually 6 cycles, most patients recover fully and back to a normal quality of life. And of course, the good thing about this treatment is that it works most of the time and places patients in a good, deep remission, what we call a complete remission, that in most cases is durable and ultimately results in a cure. So this is a really good combination of therapy. When I'm thinking about advice for my patients about treatment for their lymphoma, I really frame it in a very simple way around thinking about R-CHOP. And the first question that I've alluded to is a patient fit enough to tolerate this chemotherapy? And that's both a judgment decision, just the experience of the haematologist who's dealing with you, but it's also a little bit of an understanding about a patient's function. Are they up on their feet, able to tolerate side effects, able to resist an infection if it happens, able to fight things off? And sometimes there's an element of age and also specific comorbidities. So a patient who already has heart failure is not a patient I would want to give R-CHOP to, because R-CHOP can cause heart failure in a tiny percentage of patients. A patient who already has nerve damage, I would not want to give vincristine to, because I wouldn't want to damage their nerves more. And so there are factors like that in your medical history that could change what recipe your doctor gives. So that's patient-related issues. The other issues that could change our choice of treatment is lymphoma-related issues. And this is an area that is debated considerably amongst the haematology community. And the reason is that those excellent clinical trials that we're talking about, there's been a lot of clinical trials that have tried to improve upon R-CHOP, in fact about 13 of them, usually which add an extra drug to R-CHOP or change whether R-CHOP is given on a 14-day cycle or a 21-day cycle. And none of those studies have shown that patients do better when you randomise hundreds of patients to receive the standard therapy, R-CHOP on a 21-day cycle, or the alternative therapy, R-CHOP on a 14-day cycle, or R-CHOP with other treatments thrown in, other chemotherapies or other novel agents. And so far, none of them have demonstrably shown that R-CHOP can be improved upon in those randomised studies. Nevertheless, some doctors do give R-CHOP on a 14-day cycle where they feel a patient might want to get their chemotherapy done faster and they think they're at a lower risk of side effect. We know that 14-day cycles are much more intensive, or at least moderately more intensive on the bone marrow, moderately more intensive on a patient, and lead to equivalent outcomes to the 21-day cycle. But there are haematologists from time to time who use the 14-day cycle to deliver more intensive therapy. The other custom fit modification that I think about every time I start a patient on treatment is whether we need to do something called central nervous system prophylaxis. And this is the idea that chemotherapy goes throughout the whole body and treats everything, but there are some parts of the body that are sanctuary sites from chemotherapy. And the best example is the central nervous system, so that's the brain and the spinal cord, and another example is the testes. And these are areas in the body where we think chemotherapy doesn't penetrate as well, but we do have particular chemotherapy types that do penetrate the brain better and get across that blood-brain barrier. And methotrexate is the best example of that. And it's become commonplace now for doctors to include methotrexate with R-CHOP as part of the treatment pattern, as part of the treatment program, if the haematologist feels that the risk of central nervous system disease is high. So in patients, or higher, so in patients who have a lot of lymphoma in their body, I usually complete staging by doing an MRI of the brain and a lumbar puncture or a spinal tap to look at the fluid around the brain, and just to make sure that there's no lymphoma there already. Because I know that if lymphoma is there already, I'm going to have to turn up the volume on R-CHOP a little bit. Now, if there's no lymphoma there already, that's when we think about prophylaxis or a preventative treatment to prevent a future complication of treatment. And for patients who are at increased risk of central nervous system lymphoma but don't have it at baseline, may be at risk of having it at relapse in the future, and they're the patients where we try to give an additional treatment. And sometimes that's methotrexate into lumbar punctures with every cycle of treatment, and sometimes that's an additional 2 cycles of chemotherapy or 3 cycles of chemotherapy using intravenous high-dose methotrexate, which is done on the hospital ward. We call it high-dose methotrexate because methotrexate is actually a really useful drug that's used across a whole range of different diseases. And in rheumatology, rheumatoid arthritis, we might use it at 10 milligrams or 20 milligrams, and we're talking about using grams of methotrexate. And That's why we use the term high-dose methotrexate. But in the context of lymphoma, these are standard doses. The treatment with methotrexate is a little bit more complicated to give. It has to be given in a hospital ward because we need to flush it out of the system to stop it causing any toxicities. I'm not going to go into the detail of that, except to say that my approach to using methotrexate in my patients with lymphoma is to try to estimate what their risk of central nervous system relapse is by looking at the PET scan, and we know that there are specific factors. So patients who have stage 3 or stage 4 disease with multiple extranodal sites, meaning involvement of non-lymph node tissues, or who have a lot of lymphoma near the brain, physically near the brain, or who have testicular lymphoma or lymphoma of other specific organs, I may know from clinical trial data and other data that's been published that we need to add methotrexate in. And that's a question that your haematologist should be addressing with you as they plan treatment for your lymphoma. But many patients don't require methotrexate. Now, there are alternatives to R-CHOP chemotherapy which are used in diffuse large B-cell lymphoma, and we now are beginning to use them a little bit more selectively in patients with double-hit lymphoma. These are 3 regimens that I'll talk about briefly, and none of them are routinely used for all comers with diffuse large B-cell lymphoma. By far and away the most common regimen used is R-CHOP, and by far and away that will do the job really well. There is no randomized clinical trial that tells us that any of these regimens is better than R-CHOP, but they all have in common the idea of chemotherapy intensification to try to improve the outcome of some of the more high-risk diffuse large B-cell lymphomas. Hyper-CVAD and Codox-M-IVAC do that by incorporating that high-dose methotrexate within the standard treatment regimen and increasing the medications that are like CHOP so that it's a more intensive regimen, and also alternating the different chemotherapies between the different cycles to try to basically hit the lymphoma harder. And as I've mentioned, there's really not a lot of evidence that these regimens are better for your vanilla diffuse large B-cell lymphoma. Dose-adjusted EPOCH is more intensive. It does increase the dose of the chemotherapy, but it spreads it out over 5 days as a continuous infusion. And here the idea is that continuous exposure to cells as they're turning over means that you can more directly target the lymphoma cells and spare your normal cells using this infusional regimen. And generally speaking, I find EPOCH to be a better tolerated regimen than Codox-M-IVAC or Hyper-CVAD, although it clearly is more toxic in terms of blood counts and inconvenience than R-CHOP chemotherapy. Now, where are people using these intensive regimens? Well, because double-hit lymphoma or high-grade B-cell lymphoma with rearrangements of MYC and BCL2 or BCL6 appears to have a poorer outcome than vanilla diffuse large B-cell lymphoma, some centres, including my own, are using dose-adjusted EPOCH with rituximab to try to intensify the regimen and hit those particular types of lymphoma harder. Now, I've mentioned to you that there are different types of evidence here, and there is no randomized clinical trial that shows that dose-adjusted EPOCH is better than R-CHOP. There is a randomized clinical trial of these 2 agents that shows there's no difference in lymphoma control for all comers. But that 10% of patients with the poorest risk, what we call high IPI disease, so a large burden of disease, or for patients with double-hit lymphoma, weren't really tested by this clinical trial. The trial wasn't powerful enough to tell us whether EPOCH was better or worse than R-CHOP. So we have some case series that tell us that EPOCH is better for double-hit lymphoma, and some case series that tell us that it might be better for patients with a large burden of disease, and unplanned analyses of the randomized trial suggest it might be better for patients with high burden disease. But it is weak evidence, and for some it's been sufficient for a haematologist to sit down with the patient and say, look, I want to give you a more intensive regimen because your lymphoma appears to be a higher risk disease, but I do so with very grey evidence base underlying what I'm doing. And that's where your values and the values of your haematologist and the resource requirements of the regimen and a patient's ability to tolerate the more intensive regimens become very important factors into determining whether one of those alternative regimens will be used, because we just don't have randomised studies that say it's better, and the one randomised study suggests that at best it's the same for all comers. Nevertheless, it has been our approach in double-hit lymphoma to use dose-adjusted EPOCH followed by autologous stem cell transplantation for our patients in this hospital, where we can see rearrangements of MYC and BCL2 by FISH. And we sit down with our patients and say, look, this is a very intensive regimen. Here is the evidence for EPOCH. Here is the evidence for autologous stem cell transplantation. And these are the reasons why. The evidence is relatively soft, but we feel that hitting the lymphoma hard in the first round is really important. And for some patients, they choose to go for that more intensive regimen, but that's by no means universal practice in Australia, and by no means universal practice around the world. For double-hit lymphomas, we use central nervous system prophylaxis routinely, and so use high-dose methotrexate so long as a patient's kidneys and general fitness are good enough to allow that. So that's the potted summary really for treatment for diffuse large B-cell lymphoma. Diffuse large B-cell lymphoma, we use R-CHOP, typically 6 cycles, sometimes abbreviated to 4 for patients with the lowest risk disease, sometimes with radiation, where radiation can encompass all of the lymphoma within a radiation field, sometimes with high-dose methotrexate if we feel there's a risk of central nervous system relapse. And then for patients with double-hit lymphoma, they can be treated just like diffuse large B-cell lymphoma, or on the basis of limited evidence, some hospitals are increasing the intensity to try to get around the fact that double-hit lymphoma appears to do a little worse than garden variety diffuse large B-cell lymphoma. Now I should mention clinical trials. Clinical trials for patients are generally for patients who have relapsed disease, and this is the idea that we're testing a new treatment to try to solve a clinical problem. Now, a lot of people think that being on a clinical trial is better than having standard treatment, but you should understand that R-CHOP cures 2/3 of patients with garden variety diffuse large B-cell lymphoma, and it's probably not far off that for double-hit lymphoma. A little worse probably, but we're a little bit less certain about how well R-CHOP does for double-hit lymphoma. But by and large, the majority of patients will be cured. And so if you're not on a clinical trial for the first-line treatment of your lymphoma, that doesn't mean that you're missing out on anything. And as I've mentioned, there have been 13 randomised clinical studies of something plus R-CHOP, and none of them have shown that they're better than R-CHOP. And clinical trials are hard work to participate in. Nevertheless, in Australia, there is one clinical trial that's still running that is looking to add an extra treatment on top of R-CHOP, called polatuzumab vedotin, and that's running in several centres around the country. But this video is being recorded in June 2018, and that can change at any time. Other than that, most of the trials are limited to patients who have relapsed or refractory disease, where we're trying to improve upon the outcome of our standard approach for that, and we'll talk about that in a different video today. So in summary, diffuse large B-cell lymphoma, the most common lymphoma that we see. There's a well-trodden path for treatment, but there are some variations in therapy.